Good afternoon, everybody, and welcome to Grand Rounds. Today, it is my pleasure to introduce Dr. Charles Paul. Dr. Paul attended Iowa State. He graduated with majors in finance and kinesiology before he moved on to the University of Iowa, where he received an MBA and also his MD degree. He stayed in Iowa City to complete his urology residency. He's been on the staff here at MGMC for about the last year. And he very kindly and graciously has accepted our invitation today to provide us with a review of the utility of MRI in prostate cancer. And please join me in welcoming Dr. Charlie Paul.
Thank you. Thanks, Dr. Hallberg. Thank you, everyone who's attending live and virtually or who's watching after the fact on YouTube or otherwise. So as discussed, we're talking about MRI today and its utility in the diagnosis, surveillance, et cetera, of prostate cancer. I do not have any disclosures industry-wise. Probably the biggest disclosure that I need to make is I'm a urologist, I'm not a radiologist, and so there are some nuances of MRI that I'll touch on that certainly I rely a lot on our radiologists, and I'm definitely not the de facto expert on that. But I do order a lot of prostate MRIs, and I look at a lot of them, and so certainly we'll talk a lot of the through a lot of the pertinent points of MRI today. So some of our objectives first is just kind of in general looking at screening for prostate cancer on the population level, what the typical screening guidelines are from a few different governing bodies, what's recommended in this day and age. We'll talk about where MRI fits into that screening protocol, especially screening, diagnosis, surveillance of prostate cancer. Hopefully at least look through some MRIs and have kind of a baseline understanding and knowledge of what to look for if you ever are looking through the images yourself. And even if not the images, just the report itself of knowing when you get a big long report about an MRI, what are the important things to look at in there. I think it's also important to know what imaging can't do and what it can't tell us, and so to know a bit of the limitations. And hopefully, especially for the primary care audience, gain some cover ordering these. I think most of the time, we in urology are the ones ordering it, but I think there's plenty of patients who I'd be perfectly fine with the primary care community ordering the MRI prior to referrals. We'll talk about that a little bit. So first, Dr. Hallberg gave you some good background, but I'm Charlie Paul. I grew up in Iowa. I've lived in Iowa my whole life. I was born in LeClaire, so way over right side there. Right in the nose of the Iowa face. I went to Pleasant Valley High School and then came to Iowa State for undergrad. Like he said, I had kind of an interesting major combination of kinesiology, which was my pre-medicine major, and then also a finance degree as well. I'll speak a little bit freely that I ran cross country and track for Iowa State, and a lot of that decision for the second major was guided by wanting to do a fifth year to use up my redshirt eligibility, but it ended up being a great experience and something I really enjoyed and I think have benefited from as time has gone on. I went to the University of Iowa for my medical school. I stayed there for residency. Our residency had a research year smack dab in the middle of it that was completely clinically protected, and so it was already a standing relationship with the business school at Iowa that we were able to get an MBA that year. That was hugely beneficial. Again, one, it was just a nice opportunity to make the most of that year. I hadn't ever really expected to go into academic medicine and thought that would be a great thing. And certainly I think has been and has continued to be so. And so if there's one thing that they did not beat out of me in Iowa City, that is my love of the Cyclones. And so I was very happy to return back to Ames a little over a year ago and set up shop here. It's been a great year so far. I think I've met a lot of you, but certainly for those that I haven't, feel free to introduce yourself at some point. On a personal front, I have a lovely wife, Carly, and a daughter, Peggy, who's about 2.5. This is a picture obviously showing one, good Cyclone fanhood being raised. And then two, if there's any sign of a successful toddler summer, it's the bilateral Band-Aids there on the knees, which are pretty much a given at all times. The second one comes off, then there's another spill in the driveway and another set goes on. So first up, we're talking about screening of prostate cancer. So just as I'm sure many people have seen in their own practices and heard of, prostate cancer is very common. As far as solid sort of non-skin malignancies, it's the most common diagnosis in men. Over double the diagnoses of lung cancer, leaving many others kind of in the dust. And it is still the second most highest lethal and number of deaths as far as cancers go. So it's definitely lagging behind lung, almost half, but still a lot of men dying of prostate cancer. And so what puts you at risk? Having a first-degree relative, especially a younger first-degree relative under the age of 60, having a genetic mutation that has been previously identified, or being of African-American descent, all puts you at higher risk for development of prostate cancer. And so plenty of old adages that I even hear patients say as well, most men die with prostate cancer. Many men don't die from prostate cancer. And that is true. A lot of men do die with prostate cancer. If we biopsied every man in their 80s and 90s, we'd find a lot of prostate cancer and not a lot of clinically significant prostate cancer. However, you're looking at the numbers here, a lot of men still do die of prostate cancer. So certainly something to take seriously, and especially in the right patient population. So obviously our kind of governing body is the AUA, the American Urologic Association, and so they recommend starting prostate cancer screening around age 45 to 50. I think the verbiage that the AUA uses is very important, so I kind of bolded those. And so they say you may begin prostate cancer screening with PSA between 45 and 50. They said you should do it even younger if you're 40 to 45 with risk factors. Those risk factors, like I touched on in the last slide, African-American descent, family history, or germline mutations. They say you should offer it every 2 to 4 years from age 50 to 69. And I think that's something that's, yes, it's in the guidelines. There's a couple different guidelines, but isn't often done in practice, mostly because it's sometimes hard to set stuff up on a every 2 year, every 3 year, every 4 year basis. It's really easy to do it every year. You come in for your yearly labs. I don't think that's overkill to do it every year, but it's one thing to put patients at ease if they're worried about a PSA, that this is not something you need to trend every year, every 6 months. There's some guys that really like to check their PSA and want it done every 3 to 6 months. And this is just more in your armamentarium. Tell them, don't worry, we can check it every couple of years. The guidelines, actually, you may use a digital rectal exam as part of screening. You don't have to. That's definitely a little bit of a generational shift as far as the utility and the yield from doing a prostate exam. I still think it's an important part, especially if you're working someone up for cancer, mostly because it's part of the staging, but not something that necessarily always has to be done. And I think probably the biggest takeaway for the primary care audience from the PSA screening is to just repeat a PSA. If you get an elevated number back, it seems out of the realm or the trend of what a patient had previously, I pretty much always repeat another PSA before taking any action beyond that. Lots of things that are not prostate cancer can make the PSA go up. So trauma, infection, inflammation, sexual activity, guys riding their bike. Have had a number of guys attributed to a bumpy lawnmower ride over the summer, driving their tractor, whatnot, in this state. So it never hurts to repeat one. I usually wait a couple of weeks at least, tell them, try to avoid whatever you were doing that may have caused it. That being said, I never totally blame one of those activities on the elevated PSA. I still do recheck it just to make sure that it's not going up, up, up. And then you can kind of go from there. If it normalizes, I usually just then resume normal screening. Now, of course, AUA is not the only governing body that has cancer guidelines. I use the NCCN guidelines quite frequently, and their first statement is this: well, it's a risk-benefit discussion. You kind of hop aboard the PSA train, and it's sometimes hard to hop back off because then you're talking, well, the PSA goes up, or you can imaging, biopsy, what do you do with that biopsy, treatment, et cetera. So if they would never want treatment for their prostate cancer, no reason to start a PSA discussion at that point. But they do recommend between age 45 and 75, if you're high or average risk, to check a PSA. If it's less than 1 or if it's normal, again, repeat it every 2 to 4 years. If they're higher risk and their PSA is between 1 and 3 or average risk, you can repeat it every 1 to 2 years, a little more frequently. And if it's greater than 3, send them for additional evaluation. We use 4 in our reference lab here. Again, that kind of comes up in the NCCN guidelines. If they're over 75, 4 is kind of their threshold there. Repeating testing every 1 to 3 years if it's lower than that, or if it's above, and especially if they have an abnormal prostate exam, then send them for evaluation. Sort of the third group here is the Preventive Services Task Force. So they've been kind of up and down over the years. You could give a whole talk on this saga, if you will, but in 2012, they actually issued a grade D recommendation for PSA screening, which here essentially D means do not screen. there was probably a little bit of underdiagnosed prostate cancer over that time frame through various research, advocacy, et cetera. It was reversed back to a grade C recommendation in 2018, but that is specifically for the age group of 55 to 69 years old. Again, more or less in line with the 45 to 50. It says it starts a little bit later, but what the recommendations of a grade C decision mean are having it be an individualized decision. It's not a painting with too broad of a brush. It's really on a per patient basis. There's a small benefit of decreased mortality, but definitely the risk being overtreatment of identifying prostate cancers and then treating prostate cancers that may never have shortened a patient's life or caused them any morbidity. But also important, like I talked about, to consider family history, race, there are other comorbidities as well. So how do we use MRI or in screening, and how is it recommended to be used in screening? Again, the AUA guidelines say that you may use MRI to increase your detection of grade group 2 prostate cancers. These are what we would call clinically significant prostate cancer, something that we typically offer treatment for, or at least starting to offer treatment for. You should use the PIRADS scale, which is a MRI-specific diagnostic criteria that grades the lesions that you see on MRI as far as their risk of harboring prostate cancers. We'll talk about that more in a little bit. And if you have a lesion, you should perform targeted biopsies of that lesion, and you may perform systematic biopsies still. If you don't have a lesion on MRI after an elevated PSA and you're high risk, they still do recommend performing a systematic, unguided, what is, quote, random, I usually call it systematic, because it sounds a little more scientific than random biopsy, and then go from there. Now, NCCN has their own guidelines. This is one thing I like about the NCCN guidelines are the flow charts. I think it's easy for me to follow. I think it's also nice for patients to follow. I kind of call it a choose your own adventure book as you go. And it makes it very, I think, logical of, well, if you have X, then you go to Y. If you have Y, you go to Z, et cetera. So for the NCCN, they recommend, like I said, repeating a PSA, doing a rectal exam, workup for benign disease, BPH, et cetera. If you have MRI, they recommend obtaining an MRI. Also, you can consider biomarkers. I'll probably table that discussion. There are a couple other sort of what I just call fancy genetic type tests that you can do on the urine, blood, et cetera. If you have high suspicion based on the MRI or low suspicion, that's your next inflection point. If you have high suspicion, going with an image-guided biopsy with MRI targeting is preferred. If you have low suspicion, then you can kind of follow with PSA and rectal exam, like I talked about. So what do I do in practice in general? I'll say first, kind of the older way of doing things, or the historical way. It's pretty simple. So you got an elevated PSA or an abnormal rectal exam, then you get a prostate biopsy. That's usually a systematic 12-core biopsy. It was the standard. Kind of make a checkerboard out of the prostate and take a core from each of those locations. And then, well, if your biopsy is positive, then you get treatment for prostate cancer. If your biopsy is negative, then you kind of go back to square one and keep following and maybe biopsy again, or do what's called a saturation biopsy, where you just take a ton of biopsies throughout the whole prostate gland. Now, again, like I said, pretty straightforward. This is kind of what things look like now. This looks more like spaghetti rather than what it used to be, but it's still pretty intuitive, I think. So if you start up at the top here, you have an elevated PSA. Again, like I said, and I'll say again, always just recheck it. So if you have an elevated PSA and it goes down, I would probably continue just to monitor. If it's continued to be elevated, then I would absolutely recheck it. And then I order an MRI on pretty much everyone. I'll tell you a couple instances where I don't, and go from there. So after your MRI, well, if it's positive, that usually leads to a targeted biopsy. I'll show you what that looks like. If you have cancer, well, then it's usually talking about either active surveillance, that's close monitoring of typically low-grade, low-risk prostate cancers, or going on to treatment, typically surgery, radiation for localized prostate cancers. If you don't have cancer, you kind of start to square one, keep following the PSA, and if it rises a couple years, maybe continue getting another MRI or another biopsy at that point. If your MRI is negative, well, you got a little bit of decision on your hands. The false negative rate of MRI about 10 to 15%, so it's going to miss maybe 1 in 10 guys that have a prostate cancer that it won't find. And so at that point, if I'm concerned, if the PSA has really gone up, I'll still do a systematic biopsy from the viewpoint of they may be that 10, 15% kind of guy. Again, cancer, no cancer, same decision point as after having a targeted biopsy. Or if the MRI is negative, say they had just a marginal increase in their PSA, they're a consistent person as far as following up with their primary care and with us, then I may check another PSA in 6 months and follow it just a little bit closer for a point of time. And well, if it does continue to go up, then perform a standard biopsy at that point. So I've mentioned once or twice targeted biopsies. I didn't have any great pictures until this morning because I was doing prostate biopsies in the OR this morning. And so this is kind of what it looks like. So this is the model that we create. Essentially, when you're doing a targeted biopsy, what you do is you use the MRI pictures, you circle the lesions on the MRI, and then you just use a software to overlay that on top of your ultrasound pictures that you use in real time. Now, that means a couple things. One, you have to have the software. So we have a little bit of a traveling roadshow situation here where we share the technology, the software, essentially the machine, with a bunch of other urologists in the state. And so I try to lump these together on certain days, do 3, 4, 5 of them. And then knock them on all at once. Just logistically, that works pretty well. But when you're doing the procedure, you make your circle, and you put the two images together. I'm actually going to show you this too. So this is just me doing a biopsy. And so you have not only, and it's very small in this, but this is the ultrasound picture. You essentially have your normal ultrasound that you typically have, but instead of just showing the whole prostate, you've got a prostate with a circle with a target on it. And the target corresponds to a lesion that was seen on MRI. So taking this picture, this is actually one that I thought was helpful to look at because this lesion is very anterior in the prostate. It's way forward, and it's way out of what you would typically sample in your standard 12-core biopsy. So this is kind of looking at the prostate from above. This is looking at it sort of down the barrel of the gun. This is posterior. This is more anterior. Normal 12-core biopsy, you're going to just sample the peripheral zone back here, and you would never have probably stuck a needle into this unless you were really looking for it. So these are probably the most beneficial targeted biopsies, the one where you absolutely would not have caught it. We'll look through some cases later, some of which are super beneficial to have the targeting ability. Some are less beneficial, but this is certainly one that's helpful. So that's just a look at the after you take these cores, the system registered exactly where your cores have gone, and so you can see based on where everything was located, how you hit or did not hit the region of interest and of suspicion. So I think MRI is very helpful with diagnosis of prostate cancer. I think if you have a slightly elevated PSA and a negative MRI, you can probably watch a decent number of men with continued PSA monitoring and limit the number of biopsies you're doing. Biopsy, not the worst procedure in the world. Some guys may tell you otherwise, but it does have definitely a risk of some bleeding afterwards in the urine and stool, couple percent risk of a sepsis or infection afterwards. So as much as you can limit biopsies, I think the better. I do think it probably helps in the detection of prostate cancer and more precise detection of that cancer, of honing down to higher grade, clinically significant disease. And it also helps, the MRI helps with staging at the end of the day, because they also look at the lymph nodes and the bones of the pelvis and can sometimes pick up on suspicion for metastatic disease or even local invasion of the tumor itself. I think it's also helpful in treatment. For surgical planning, it can help a lot with how we manage the bladder neck as far as the anatomy of the prostate, sometimes how we approach the nerve spare, how aggressive we are on the sides of the prostate with being right down on the prostate capsule versus going a little wider if there's disease there. And can also sometimes help us guide us if there's suspicious lymph nodes, of how large of a lymph node dissection we need. I'm also not a radiation oncologist, but it can be helpful for determining who might be a candidate for more local brachytherapy techniques. Also for their treatment planning, the radiation oncologists pretty much always have an MRI ahead of time at some point. I think it's also helpful for counseling with BPH symptoms. So not just how big the gland is, but what the anatomy of the gland is in terms of what lobes of the prostate may or may not be enlarged, and how you counsel patients regarding what their future urinary tract symptoms may be down the road after surgery, but specifically after radiation, where maybe BPH management gets a little more complex after that. What are the downsides? Well, it's an MRI, so there's some cost to it, of course. It's time. Patients got to lay there for 40, 45 minutes, listening to music. Some patients may not tolerate an MRI great from a claustrophobia perspective, from a back pain perspective. Some patients aren't candidates based on implantable devices, pacemakers, neurostimulators, et cetera. I think the main probably group that I don't order MRIs in, if I have a high suspicion for metastatic disease, say someone comes in with a three-figure 100, 200, 300 PSA, may not need an MRI up front. Oftentimes, a systematic biopsy is going to be enough, and they'll need staging imaging of some variety after their diagnosis, oftentimes with PET imaging in this day and age, but not necessarily someone that has to have one up front. So, of course, this has been studied as far as evidence goes for where we might see benefit from MRI. There's one big trial, which was called the Precision trial. Prostate cancer is notorious for always having to have a catchy name associated with their trials. Sometimes they have to work really hard to pick the words and which words they include in the title. This one is the Prostate Evaluation for Clinically Important Disease, Sampling Using Image Guidance or Not. And so they got precision out of that. So this was a couple years ago in the New England Journal. It was a randomized non-inferiority study comparing MRI with or without a targeted biopsy after having an elevated PSA versus just proceeding with a systematic biopsy only. And so they were looking at either purely MRI targeted biopsies or purely systematic biopsies, sort of the purely targeted or the older way of doing things. And their threshold was, well, are they detecting clinically significant prostate cancers? So these are typically grade group 2 or in Gleason 7 or above. It was a multi-institution study with 500 patients, one of the biggest in the prostate MRI world. And is looking at patients that had MRIs, about 70% of them had a lesion found on their MRI. In terms of detecting clinically significant prostate cancer, there was more of that detected from MRI-targeted biopsies than without. Insignificant cancer was the opposite. You detected less using an MRI for your targeting. You detected more by doing systematic biopsies. There was not perfect correspondence between the MRI reviews. They had local centers that were actually doing the initial MRI reads, and then there was a central MRI review. I'll say 78% pretty good, not perfect, but certainly could be worse. A couple downsides of this trial: there's no control in the MRI read initially. It was just reviewed at a later date. There was also no control in the approach of the prostate biopsy, whether it was a transrectal or transperineal approach or the type of software they used for the fusion, or if they were using what we call cognitive fusion, which if you have a lesion that is very easy to see where it would be on ultrasound, and it's not an enormous prostate, it's perfectly reasonable to do what's called a cognitive fusion, which is essentially doing a biopsy in the office without the fancy software, going after that area, especially if, say, they have a nodule on exam that corresponds to something on an MRI. It's going to be pretty straightforward to treat. I think some of the take-homes here on this graph is just looking at, well, based on the degree of abnormality on MRI, which this is the PIRAD scale that I mentioned earlier, what's your chance of finding cancer? And so PIRAD's 3. The green here is the clinically significant cancers. The blue is the insignificant, and gray is no cancer. And so really this is exactly as you would expect. If someone has a higher suspicion of lesions, so if you go from 3 to 4, 4 to 5, your chance of having a clinically significant prostate cancer goes up. Your chance of having no cancer goes down to the point of if you have a P5 lesion, kind of talk about what that means in a few minutes, you're pretty sure you're going to find some sort of cancer, whether it's significant or insignificant. And this is especially, I think, it also illustrates just not only the accuracy of MRI, especially in terms of the rating scale, but if you have something that is very abnormal on MRI, it's probably going to be a cancer. There was a couple meta-analyses that are out there. One's from the Journal of Urology that looked at 29 studies, 13,000 patients, a whole lot more than 500, looking at MRI-targeted biopsies versus systematic. Again, higher rate of detection of any prostate cancer, higher rate of detection of clinically significant cancer. They only had a 2% higher rate of high-grade cancers, but there was no difference in this review of clinically insignificant cancers. When you took the systematic biopsy component away from doing a targeted biopsy, they did actually lower the rate of clinically insignificant prostate cancer, and they did not find any difference in significant or high-grade cancer. There was a Cochrane review a few years ago also that was another systematic review. They looked at 18 studies, both biopsy-naive and people that had prior negative biopsies, having MRIs done, having targeted biopsies based on those MRIs. The pre-biopsy MRI sensitivity was 0.91. That seems to be pretty true. Like I talked about earlier, I usually quote about a 10 or 15% chance of missing a prostate cancer. That's right in line there. However, the specificity, not quite as great. Of course, we saw on that earlier study that there's plenty of men that have an abnormal lesion on the MRI that may be a clinically insignificant cancer, or it may not be cancer at all. And so, that goes to the importance of just counseling and talking about this MRI result and what it might mean for that patient. They talk about an MRI pathway, which is essentially having an MRI done and then combination having a targeted biopsy following that MRI. If you pooled people together that both had a prior biopsy and who had not had a prior biopsy, the MRI pathway had a better detection rate of the 95 confidence interval being above 1. If they had a prior negative biopsy, it was even better. So those guys really benefited. And I think the one fusion biopsy example I gave, if a guy has had a negative systematic biopsy, the PSA is still rising, it always makes us suspicious that maybe we're just not biopsying the right part of the prostate, and those guys really benefit from a targeted approach, just if it's outside the normal template. It was not quite as beneficial for the biopsy-naive guys. It didn't reach clinical or statistical significance there. So they essentially said, well, the prostate pathway increases your significant prostate cancer, probably reduces your insignificant prostate cancer, and limited a little bit by heterogeneity and inconsistency. I think the one reason I wanted to lead off with the precision trial is it's probably the biggest and best trial. A lot of the prostate MRI studies have been single institution experiences, not a lot of patients, and that's just in general going to lead to a lot of heterogeneity in the data. In terms of reading MRIs, again, I'll say it again, I'm not a radiologist. For MRI, I rely heavily on our radiologists. I feel pretty good about reading a kidney stone CT scan. There's one bright thing that's a stone and a sea of everything that's dark and gray. The MRIs have a lot more nuance to them. So I always kind of blame the radiologist. It seems every time I open a scan, there's one more phase and one more way they're processing the data just to keep us on our toes. But I think it's still important to always read your own scans. I think anytime you're ordering a scan, you should look at it, whether or not you know what you're looking at first. It's going to help you learn and be able to interpret better in the future. And I always try to look at the pictures. And so I think that's really important. And in time, you get better at it. And it becomes more helpful just to look at it with your own eyes too. And so in general, this is a clinical urologist overview, not necessarily radiologist, but I think a decent overview nonetheless. So just some basics about MRI phases. Looking at anatomic phases of MRI, this is what you're going to look at to see, well, what does the gland look like? Anatomically, the size, the shape, etc. T1, not utilized a ton. It's not utilized at all in the PIRAD scale. It can identify hemorrhage, prior bleeding, especially from a prior biopsy. T2 is really going to be the workhorse. That's going to give you the best resolution of what the prostate looks like in terms of the anatomy, the different lobes, the zones. Excellent resolution. On a T2 image, prostate cancer typically appears dark, looks kind of like a black smudge, like someone took charcoal and rubbed it across, usually poorly circumscribed. BPH nodules, on the other hand, are typically well circumscribed. So if you see a circle of something that looks like a little globe or a marble in the prostate, it's probably not prostate cancer, it's probably a BPH nodule. The peripheral zone usually has higher signal, it's brighter, it's usually pretty homogeneous. The transition zone is usually more heterogeneous, that's where a lot of the BPH arises. Central zone is going to have your lowest signal. In addition to the anatomic, there's a couple very good functional phases. And so those are the DWI, the diffusion weight imaging, which usually shows up prostate cancer as bright. There's an apparent diffusion coefficient map, or the ADC, where prostate cancer is dark. I'm a pretty simple guy as far as remembering things. So the way I initially remembered it is that if you rearrange ADC into DAC, it sort of looks like dark. And so I say that means dark, and then DWI has an I in it, and so does bright. So that's how I remember it, which whatever mnemonic gets you through, I'll take it. It's also a contrast-enhanced phase where they get gadolinium contrast, and it can detect enhancement, just like many cancers do, have angiogenesis, neovascularity that helps determine whether or not it may or may not be a cancer, and these typically light up. What we'll see in the PIRAD scale is it's not the sole determiner, but it can help upstage if something does have enhancement. The PIRAD scale I've referenced a couple times. This is a standardized scale for rating prostate MRI. And so a lot of primary care providers who order mammograms may know the BIRAD scale. It's very similar to that, just for prostate. So it's the prostate imaging, reporting, and data symptoms. It's a sort of combined effort between the American College of Radiology, the European Society, as well as a foundation. It's supposed to be a standardized scoring system. What the goal is to predict clinically significant prostate cancer, grade group 2 and above, ones that we might treat. So Gleason score greater than or equal to 7, larger volume cancers greater than half of a milliliter, and especially cancers that may have some local invasion extending outside the prostate. Lesions are scored on a 1 to 5 scale, 1 being the most normal, 5 being the most abnormal. That's based on the T2 and the DWI phases and the ADC a little bit. And really we're looking at, and as well as some upstaging from the presence or absence of enhancement. And it does depend on the location of the lesion when we go through this. So the prostate's broken up into a bunch of different zones. You can blame me for this artwork, but you get the green is the peripheral zone. It's kind of surrounding the back. This is not totally to scale. Usually what we're thinking of is more of the posterior, but in order to show the whole prostate, you kind of got to fudge a little bit. The transition zones kind of surrounds the urethra, which is the yellow thing on the inside. You've got the central zones, kind of where the seminal vesicles and the ejaculatory ducts enter, and then anteriorly, the anterior fibromuscular stroma. And so peripheral zone stuff that's typically more posterior, going to be really easy to hit. It's really on a standard biopsy. That's usually what you're sampling majority of. It's the transition zones, the anterior stuff that really, I think, where MRI plays a great role, especially in diagnosis and performing a targeted biopsy. So as far as the T2 imaging, these slides break all the rules of good PowerPoint presentations because it's a lot of text, and it's really just here for illustration of, well, there's a standardized protocol for reading these scans, and it's an attempt to be pretty algorithmic of if you see this, that means that. If something is bright or dark, it means something very specific in terms of the PIRAD scale. So on the T2 phase, it depends where this lesion is. Is it in the transition zone or the peripheral zone? If it's in the transition zone, obviously it ranges from something that is normal appearing, like a typical nodule or BPH, all the way up to something that is lenticular, abnormal, non-circumscribed, homogeneous, typically dark, hypointense, and the real delineation between a PIRADS 4 and a PIRADS 5 is in the size. So if it's small, then it's typically a 4. If it's large or it looks like it is invading outside of the prostate gland, that bumps it up to a 5. For the peripheral zone, kind of the same deal. You're going, it's normal for 1. If you're looking at the 4s and 5s, ones that are likely to be cancer, they are sometimes circumscribed, sometimes not, homogeneous, dark, hypointense, and either small or large, or demonstrating behavior of growing outside the gland. For the DWI, diffusion-weighted imaging, here you're looking at something that's going to be bright in either the transition or the peripheral zone, ranging from no abnormalities to something that is very bright on the DWI and very dark on the ADC. So if you have something that fits those criteria, again, a little bit based on size and also location, but this is the general scale that they use for the DWI. The enhancement, really it's just either negative or positive. If it's negative, it doesn't enhance. If it's positive, it does enhance. And it's looking at, well, is it focal in that area that corresponds with the lesion on the other phases, or is it early compared to that, and what's the correspondence? A really nice thing, if you look through these images, the radiologists make it pretty easy on us because the first series that usually pulls up automatically, if you scroll through that, it's really going to show you pretty much everything that they saw. Now, still, I think it's good to look through the whole scan, but it will show usually a measurement slide that shows the size of the prostate gland on the T2. It'll show a circled or green arrow sign of the suspicious lesion on T2. And then if you just scroll through, it'll flip right to the DWI and ADC phases that correspond. And so usually if you see something dark on T2, bright on DWI, dark again on ADC, your suspicion is going to be higher that it is a prostate cancer. You put all this together, all of this PIRAD stuff, and it's really sort of a table that you just move across as far as checking your boxes. So say for peripheral zone, if you have a score of 4 on the DWI, it actually doesn't matter what the T2 is for the peripheral zone. Boom, you go straight across to a PIRADS 4. The enhancement comes into play really for a DWI of 3. If it does not enhance, it stays a 3. If it does enhance, it bumps you up to a 4. And that's generally the same for the transition zone, but it does bump you up from 2 or 3. The DWI can actually be what changes you from a 2 to 3 or from a 3 to a 4 there. So these are what they're looking at. I think, again, if you read through the reports here, it's really nice, not only on the image side of things, but on the report side of things. It's really a pretty standardized template where if you look through a lot of these scans, all the radiologists pretty much put stuff in the same order. They're going to start with the size, the shape, what was their recent PSA, then they'll talk about the lesions, what do they look like on these various phases. And so it's nice that you can pretty much always know what to expect, and there's a lot of consistency amongst the providers here, which has been really helpful. So what does the PI-RADS score actually mean? Talked a lot about, well, 1 through 5. Obviously, you have to do something with that information. And so really, it does predict your chance of having prostate cancer. And so whether you talk about the risk or the likelihood, it's just different, essentially, ways to say the same thing. A higher PI-RADS number is going to be a higher likelihood, a higher risk of having prostate cancer. And so when you're looking here, 3, 4, or 5, that's really the threshold to, I would say, worry. It's the threshold that I usually use whether or not to do a biopsy of something is a level 3 or above. For having any cancer, usually I say 15, 20%, maybe 25% from a PI-RADS 3. For PI-RADS 4, it is likely, and when patients read the report, they'll see high risk and likelihood of having prostate cancer. And a lot of times that's a little bit alarming to them. I oftentimes have to tell them that, yes, it is likely if you play the odds, but it's more than a coin flip, but not that much more than a coin flip. Any cancer, 50 to 60%. Clinically significant cancer, less than that. A PI-RADS 5 is probably a little bit higher than this. This is one of the tables from the AUA, but 85%, probably pushing 90 plus percent if something is behaving in that way, growing outside the prostate gland. Not a lot of those are coming back as benign. So I usually tell them, well, a level 3 is something that we should probably look into. A level 4 is probably prostate cancer, but I wouldn't lose sleep over it. A level 5 is, I would tell you, I would definitely bet that it is a prostate cancer. Whether or not you need to do something or what you need to do really depends on the pathology. So let's look at some cases. So again, quick review. The green back part here is our peripheral zone. Red transition zone a little bit in front, the central zone, and the anterior fibromuscular stroma. So patient number 1 had a just screening PSA, followed for a number of years. He had it obtained last in October. He had actually had a higher PSA before, up to 6.79. It was rechecked, and it did come down a little bit to 5.6, 5.7, but he also had a nodule. So someone that, you definitely have some suspicion that something is going on. So this is a good warm-up here. So here's our MRI from this patient. And so these are, I oriented these all the same. So you've got your T2 up here, your DWI over here, and your ADC down here, and then this will be a sagittal T2 that shows you kind of the relation of the prostate to the bladder up here. And so these are all axial transverse sections. So this is the prostate here. That's something dark. It is a little bit circumscribed, I'll say. It doesn't have that total lenticular, creepy crawly look to it. As I said, he did have a left-sided nodule as well. But definitely corresponds on the DWI here, really bright. On the ADC, really dark. So definitely an abnormal and suspicious lesions kind of fit in all those characteristics in. So we took him after the prostate MRI, showed a 1.2 centimeter PI-RADS 4 lesion in the left posterior midgland, essentially exactly where his nodule was. So we took him for a fusion biopsy. He had grade group 4 in the region of interest in 2 of his 3 cores. He had grade group 4 in the left lateral systematic biopsies. And I guess I should say a side note, I usually do still perform systematic biopsies, sampling outside the region of interest, mostly because of that 10 or 15% negativity of the MRI, just in case you do find a cancer elsewhere in the gland, especially on the contralateral side if you're planning treatment. So you have to think about it a little bit. When I do a targeted biopsy, I'll usually take those cores and then kind of pretend that I didn't do anything, and I do the same 12-core biopsy that I do any other time. So I think in this gentleman, that left lateral core was probably just sampling that nodule, same area, and he had a little bit of grade group 1, clinically insignificant cancer throughout the rest of the prostate. So based on his grade group 4 disease, he was high-risk prostate cancer, which usually necessitates some extra imaging. So he had a bone scan, which is negative for any Mets. We talked about surgery and radiation. He went for radiation, so he did a course of androgen deprivation and then combined modality, high-dose brachytherapy, which we administer through acetylene needles, and then an external component as well. And his PSA and follow-up is currently undetectable. So this is a guy, looking back at this, I questioned, well, did I really need to go through the whole rigmarole of doing a targeted biopsy on him? He had a suspicious nodule. He had an elevated PSA. I did detect that probably same cancer based on the systematic biopsies alone. So my knee-jerk reaction is, well, no, I didn't really need the MRI for the diagnostic standpoint. Now, the plot thickens a little bit for him as he's has a hypercoagulability. He's on lifelong Eliquis. He had a prior saddle embolus after an abdominal surgery. And so this guy, his biopsy gets a lot more high risk when you talk about all those things because you're coming off the Eliquis, so put him at clot risk for a few days. You have to come back on your blood thinner after you just poked a bunch of holes in the prostate, which has a lot of blood vessels in it. And so I think, hey, if there's a tiny chance that this is a BPH nodule that you felt and he just has a big prostate, and we could have ruled that out with the MRI itself, that would have been worth its weight in gold. Now, it wasn't that, and so here we are. But I still think in some situations it's more than just, well, what's their PSA, what's their prostate look and feel like. You take the patient characteristics, into play as well. And certainly, if I could have avoided a biopsy in him, I would have loved to. Next case, this is a gentleman with PSA 5.06, a little bit elevated, who I had rechecked, and it was right around there. And so this is his prostate MRI. And he's got not the biggest prostate in the world, but here's the T2 image. He's got a little bit of kind of what I call smudgy, dark changes throughout the right side and moving on a little bit into the left side. He's got a little bit brightness there on the DWI, maybe a little bit up in there, and then some corresponding darkness here on the ADC. This is, again, sagittal view, prostate sitting down here in relation to the bladder. It's also helpful to look at this and sometimes see, well, bladder's a little bit thickened, maybe a little bit trabeculated, can give you some indication of what their urinary symptoms might be or might have been previously. So prostate MRI on him, read was a 1.2 centimeter Pyrides 4 lesion in the right posterior lateral peripheral zone. So it was really circled as this guy with the more increased uptake or signal there on the DWI. I thought that this, sorry to flip back and forth here so much, this location, not a huge prostate, pretty accessible through the peripheral zone. I did not take him for a formal fusion biopsy in the operating room. I performed what I referenced earlier, kind of cognitive fusion in the office, and it was actually even more helpful because when I looked with the ultrasound, he had a hypoechoic area within the prostate that really perfectly corresponded to this, so it was a pretty straightforward deal to target. And so from that region of interest, office biopsy, he had grade group 5, the most aggressive grade group of prostate cancer from pretty much all of those cores that came out. He also had grade group 5 on the systematics, which again, we're probably sampling that same area, same location as the region of interest. He had a little bit of grade group 2 on the left side, which I think probably corresponded to some of that mild signal change on the MRI. So he's high-risk disease. Based on that, I did get a staging PSMA PET scan, which was negative. And so he's on for a robotic prostatectomy and a lymph node dissection coming up. So again, one that probably would have been able to find without the MRI. However, I do think it's helpful in planning the operative approach. For him, he's got a lesion that is way far off to the right here, kind of abutting the right lateral aspect. And when we come around the edges of these, that's where their nerves are that help primarily with erections, maybe a little bit with continence after surgery. And if you can spare them, great. But this is probably not one that I would hug right on the prostate capsule. Maybe go a little wider on the right and spare his nerves a little bit more on the left. Next patient had a PSA again, but of around 5, confirmed on a couple draws. And so this is his MRI. So here you can tell it's a little bit different as far as how the resolution came out, but this is the T2 image. So I think one thing to note here is this sliver down there, that little crescent, that's the peripheral zone, and then this is transition zone. So this is a big prostate. This is a lot of BPH, so that's pretty large. This is the dark smudgy area that we're going to be concerned about. That's pretty far forward. That's way up there. See a little bit bright there, a little bit dark there. Here is a very telling picture of this is what happened when prostates get big. They start to bulge in. Where he's urinating from is the middle of the donut holes through here, and not a lot of real estate there. More of a slot canyon than the Grand Canyon, and it's starting to kind of protrude with an intravesical component here up into the bladder. So this was also a P4 lesion, just barely under 1.5 centimeters, but extending from the anterior peripheral zone, kind of fibromuscular stroma from the base to midgland, a bigger prostate of 80 grams. I did do a fusion biopsy on him. I think these are probably the most beneficial ones that are outside the realm of a normal biopsy. They're way through the prostate, and you want to be able to hit it right. So he had grade group 2 in all the biopsies from the region of interest. He also had a little bit from the right lateral and the left lateral, which you may not have expected based on the initial MRI read. And so he's favorable intermediate risk, and he also elected for surgery, having a robotic prostatectomy and lymph node dissection coming up. He's one, MRI is extremely helpful. So I would not have routinely biopsied an inch or two through his prostate up to there in the office. So, he could have had a couple biopsies through the years, rising PSAs, and he may not have found all of that. Now, he may have found a little bit of disease elsewhere, but it does change a little bit what you know based on having a larger burden of disease in the anterior gland up there. Secondarily, this changes a lot kind of what you're expecting to do during surgery. Bigger prostate gland, you're going to have to manage the bladder neck a little bit differently. When we're freeing up the bladder from the prostate, we're kind of approaching from up here. We have the bladder dropped down off the anterior abdominal wall, and you're essentially dissecting here through the neck of the bladder, peeling the bladder up and the prostate down. If you know they have a big median lobe, it definitely can put you at a little bit, have your ears up as far as knowing what to expect here and how to handle that alteration in anatomy. I think also I do counsel patients a little bit differently as far as they are expected to have a really wide bladder neck that you might have to tailor, put them back together a little bit differently, slightly higher risk of needing to keep the catheter in longer, having a leak afterwards that they need to drain for or something like that. Alternatively, with the size, it does change your counseling for radiation treatment as well, where a patient may be more inclined to do one thing or another if they have an enormous prostate, may need even an outlet procedure like a TURP or an enucleation before radiation if they're already bothered by symptoms. This patient is a story that I think probably we've all seen plenty of pre-biopsy PSA being elevated back a couple years ago, having a benign 12-core biopsy, and then, PSA continued to be elevated. Now, his did actually go down slightly, but it was still elevated outside the normal range. But negative biopsy, PSA was still elevated. We elected to get an MRI. This one, here's your T2 up here. He's got this little tiny deal down here in the peripheral zone. Again, another big prostate. Bright over here, and then that little thing dark down there. This is another big guy growing kind of up into the bladder, big, thick bladder, likely from years of having to compensate for that big prostate and continue to get the urine out. So, like I said, his 12-core biopsy initially was benign, which you would expect that based on this location, you could definitely hit that. However, if you're still taking 12 cores out of a 40-gram prostate versus a 150-gram prostate, you're going to be sampling less of the gland, and your chance for missing a small lesion goes up. And so he had a Pirates 4 lesion there. We did a fusion biopsy targeted and found grade group 2 in all the biopsies from the region of interest, grade group 2 and some of the left-sided biopsies as well. He had some perineural invasion, which doesn't totally change your staging, but does make you a little bit more concerned about a more aggressive cancer process. And so he is also scheduled for a prostatectomy coming up. Like I said with the last patient, big prostate, extra counseling as far as need for bladder neck reconstruction and what his continence expectations might be after surgery. For him also, I know that lesion and the primary bulk of the cancer is over on the left side, kind of adjacent to the edge of the prostate. And so I'll probably go a little bit wider on the left side and hug it a little bit tighter from the nerve perspective on the right. I think this situation, big prostate, small lesion, is kind of a needle in a haystack phenomenon where, yes, you might hit it, but you might not if you're just taking systematic cores throughout. So just a couple more left here. This gentleman's first pre-biopsy PSA was 5.8. He had a negative biopsy a couple years ago. Again, PSA actually rose this time and rose quite a bit. Had doubled over the years. And so he had an MRI done as well, which here is another evidence of anterior sort of hard to find disease. So this one doesn't show up quite as well on the T2 image, kind of anatomic image here, but this is where you'd expect it to be. It shows up really nice on the ADC, and a little bit brightness maybe in kind of the midst of that there, but kind of normal sized prostate for this guy. I think this is the most telling image here, that big black mark, kind of out of normal from the rest of the surrounding tissue. So he had, again, P4 lesion, far anterior transition zone, spanning a decent amount of the gland. Fusion biopsy showed grade group 2 and half the cores from that region of interest. All of the systematic cores were negative that I took. And so he was unfavorable intermediate risk based on all of his criteria. He has already had his surgery, so he had a radical prostatectomy back in April, as well as lymph nodes. And because of we knew where the disease was, it wasn't down at the bottom of the prostate at all. It was all up front. We were able to spare all of his nerves on both sides, and he had consistent pathology, grade group 2. He had negative nodes and negative margins. So MRI, really helpful for this guy. Would not have found this one for a while without really either taking his prostate out or doing a very invasive number of biopsies. In each biopsy that you take, the marginal risk isn't that high, but you keep adding these up and, can have some real risk of bleeding and infection afterwards. So that ends up the cases. So just quick to review what our objectives were. So typical screening guidelines, PSA every year or two, sometimes even every 2 to 4 years is fine, but I think every year or two is perfectly adequate from around the age 45 if you're standard risk, maybe at age 40 if you're high risk and you've had a family member that's had prostate cancer at a young age, up to about age 70. Now, it's hard to get a lot of guys to stop checking their PSA. I talk about it every single day. A lot of them want to keep checking it. There's not a lot of harm in that. Yeah, is there harm in ultimately doing a biopsy or some other stuff? Yes. But really, after age 70, I tell them that the chances that a prostate cancer goes from 0 to lethal in the rest of their time frame on a population level is low. Now, you're not talking with populations in the clinic, you're talking with individual patients. So it really depends on, what are their comorbidities, how active are they, what's their life expectancy, et cetera. But that's in general the guidelines and can give you some data to convince some folks otherwise. So as far as our role of MRI and screening, I think it helps with your precision of diagnosis. I think it probably helps with leftover diagnosis. I think it helps you avoid a couple biopsies. I think it does help in treatment planning as well if that time does come. I think things you're looking for on the MRI, big takeaways, is on the T2 phase. That's going to be the anatomic one. That's the one that you can actually see stuff on. It's going to look like a dark smudge. The DWI and ADC, it's going to be bright and then dark. You put all those things together, and that's going to give you your PIRAD score that tells you what are the likelihood of having prostate cancer. Limitations are really that 10%-ish, maybe 15% chance of a false negative. I usually, with a negative MRI, if they have a mildly elevated PSA, just continue to follow the PSA for a little while longer. If it consistently rises, I think it's probably a good idea for most guys, especially in their 50s and 60s, if they're young, they don't have a lot of other health problems, to rule out a prostate cancer that we're missing. In guys who are coming in and they've had 3 heart attacks and a stroke in the last year and they're on oxygen, it might not be worth putting them through a biopsy in that situation, and being a little bit more conservative might be better in their case. And then gain comfort in ordering. So I think, again, for the primary care audience, I'm fine if you want to order a prostate MRI ahead of time. The only request I would have is just always double check a PSA. So get that second PSA. If it's still elevated, feel free to order, or you can just even ask us too. I think as long as you know that, if you know in general what you're looking for on an image, and in general how to interpret it, and tell the patient, hey, this is the probability, you're going to see the urologist and you'll probably need a biopsy. If it is a PIRADS 3, 4, or 5, then go ahead and order it. I think it can expedite things a little bit. If you want me to do it, I'm happy to do it too. So if any questions, on a individual patient standpoint, you can always send a MyChart message or give us a call if needed. And lastly, I should say that amongst the 3 of us, myself, Dr. Deitch, Dr. Correct, there's some nuanced difference, but we pretty much all have the same algorithm as far as how we handle these things. Most all of us are ordering MRIs pretty early prior to biopsy. Maybe some little differences here and there, but pretty much standardized practice between the 3 of us these days. So that's what I've got for you. I'm happy to answer any questions for anyone either here or online if they have them. All right. Well, enjoy some more pizza and have a good rest of your week. Thanks, guys.